Good afternoon, everyone. iTech India welcomes all the participants for today's Regional Distance Learning Seminar Series. Today's topic is Advanced Disease Management in Children Living with HIV less than 5 years of age, and the speaker is Dr. Preethi Nagaraj. Dr. Preethi Nagaraj is currently working as the Professor Pediatrics with the Pediatrics Center of Excellence and is the Nodal Officer at the ART Center at the Niloufer Hospital, Hyderabad. She is a national trainer for IMNCI, FBNC, Basic and Advanced Neonatal Resuscitation Program. She also manages the Adolescent Center for Excellence, that's UA, at the Niloufer Hospital. We welcome you, ma'am, for today's session and request you to start the session.
Thank you so much, Shweta, for the kind introduction. And I welcome all the participants and hope to have a good learning session now. So let us begin. Just allow me to do this. You're able to see my screen?
Yeah, ma'am's screen is visible. Please click on the slide and then click next. Yes.
Yeah. So the objectives of this session is we want to know what are the major causes of morbidity and mortality in the CLHIV patients. Right. Second is what is this package of advanced disease management in CLHIV patients under 5 years of age and treatment of tuberculosis in CLHIV patients. So let us begin. What is the advanced disease management in CLHIV patients less than 5 years? So before that, I just want to say that what is advanced disease management? What happens in India? 2.3 million patients are there with HIV, of which 30 to 40% have CD4 count less than 200 per millimeter cube. But what is happening is 20% have less than 100 cells. So these people will be presenting as advanced disease, and of which what happens is even if we are starting the therapy earlier, if the CD4 counts were less than 200, what is happening? There is a 50% chance of mortality more than if the CD4 counts were more than 200. You got my point? Therefore, we have this package. So what is this package of ADM is to reduce the mortality and morbidity? How? By using prophylaxis, diagnosis, and using the point of care technology, right? So this is what we will learn, that how we can do it after initiating and how to manage the cases, right? So HIV in children less than 5 years, 80% of the children less than 5 years who are not already receiving ART and clinically stable but have severe immune suppression. So these all children less than 5 years are considered to have advanced disease. These children will have very high mortality. So mortality rate in the CLHIV children, per se, if they are less than 5 years of age, the risk is almost 28.2%. When their WHO clinical staging is advanced staging, it is almost to the 38.6%. Children who are malnourished will have 22% mortality, and severely immune suppressed children will have 35%. So these numbers are very alarming. That's why this whole program and this session is about. So advanced HIV disease. Newly diagnosed CLHIV child less than 5 years, severe immune suppression following the treatment failure, or the patient who is re-engaging with the care after treatment interruption. Child has taken treatment for some time, goes off and again tries to come back. Now note here, children older than 2 years who are stable on ART at least for more than 1 year and who are clinically stable should not be considered to have advanced disease. So who is the stable child? Child more than 2 years and satisfying all the other criteria. What is that? Child is receiving ART for more than 1 year, as we said, and the viral load is suppressed. That means less than 1,000 copies. Child should be on the same regime. They are not going on changing the regime. and the child is not having any active illness. And most important in our this thing is adherence. Is it not so? All agree on that? So treatment adherence should be more than 95% for the last 3 months. Okay. Child's weight for age should be more than 2 standard deviation, or the weight for height should be good, more than 2 standard deviation. Right? So these are all the criteria. When it is there, we will say this the child is stable. Right? So that is not the case which we are discussing. We are going to discuss advanced disease. So those who are already having the viral load suppressions, who are having good CD4, weight is good, height is good, adherence is good, such children are not they are stable cases. So we are going to see children less than 5 years who are newly diagnosed, immunosuppressed, or child has had interrupted the therapy and again restarted. Got it? Till here everybody is okay with it? My pace is okay. I am audible. You are understanding what I want to say?
Participants can write in the chat box, please.
Okay. So now further we are going to go. What can be the major cause of why we want to see this advanced disease? Because advanced disease, as I said, that will cause more mortality and morbidity. Is it not so? Mortality will be more than 50%, I said. So if that is there, what can be the cause of mortality? See, mortality can be because of pneumonia, which will include the PCP pneumonia. It can be tuberculosis. It can be bloodstream infections, like we call septicemias, diarrheas, and severe acute malnutrition. So these are all the major causes which can lead the child to the morbidity and mortality in the child. So do we have any percentage when you are saying pneumonia, TB, blood infection, diarrheal infection, SAM? If these are the causes, do we have any evidences or percentage? How much pneumonia will cause death? How much percentage of tuberculosis will cause death? Yes. So see, almost 30%, 38% of pneumonias, including PCP, can cause mortality in children, and 28% children because of co-infection with tuberculosis, 20% with sepsis, that is blood infection, or children with diarrheal disorder and SAM, 10% of the children will have mortality. Okay. So what is a package of advanced disease management in CLHIV children less than 5 years? So do we have any evidence to know that yes, baby, these are the studies, or from on basis of this we can do the package? As I already said, package will be to reduce the mortality, we will, and morbidity. We will start the therapy early, and we will try to give the prophylaxis. We will try to prevent. We will try to do the good counseling. And one point of care technology we are going to use. So if this was there, do we have any evidence why we want to do this package therapy for these children? Yes, per se, the studies are not there for the children. But what we have done, we have had the studies for the adults. Okay, so the adults have the study guidelines from two main trials. That was REMSTART and reality. So what has happened in the REMSTART, they have all the participants above 18 years only. So we just took their guidelines. But in reality trial, what happened was 4% of the participants were children. That is between 5 to 17 years old. Children also were taken into the participation. So they from there we have taken some guidelines. Okay. So 2017 guidelines were focusing on providing enhanced package for prophylactic, diagnostic, therapeutic interventions for those starting ART with advanced HIV disease, right? Evidence on the management of advanced HIV disease specifically related to children is very limited. There are no RCT trials for children less than 5 years. So based on the REMSTART and realities trials which are done in the adults, we have taken some guidelines. Okay. So advanced disease package for CLHIV should be offered to children and evaluated for pneumonia, TB, bloodstream infections, diarrheal infection, and SAM. Okay. As I again said, there is no randomized study for them. And so what intervention we have to do? We should do stop. So what is this stop? The whole session we will talk about stop now. So stop is screen, treat, optimize, and prevent AIDS. Right? So interventions to reduce morbidity and mortality among children living with HIV, we will screen them, we will treat them, we will optimize the therapy, and we try to prevent AIDS. So how are you going to do screening? What all we screen? In every center, what we do screening for tuberculosis, 4S. You all remember 4S? Yes? Say in the chat box, yes, you know all. Huh? So we will do TB screening for cryptococcal infections, for malnutrition. Once the child enters into our ART center, are we not seeing the height, weight, mid-arm circumference, any source of infection is there or not? All these things we will do in our center. Is it not so? But we are going to screen for the tuberculosis foremost. Yes or no? So these are in detail, we will give you the thing. So for tuberculosis, 4S is there. Okay. What all are the 4S you remember? Anybody who can tell me? 4S. Contact should be there, weight loss should be there, child should be coughing, and child should have a fever. So we will use the algorithm, then we will use a diagnostic test. We want to confirm. If the screen test was positive, we will confirm with what? We will see the CBNAT. Okay, na rapid molecular diagnostic test. We will use the CBNAT, or we will try to induce the sputum. How shall we do it? We will do the gastric aspirate. Is it not so? We will give the saline and through the OG feed and take the gastric aspirate. Or other extrapulmonary sample. What are the other extrapulmonary sample most commonly we see is lymph nodes. Is it not so? So cervical lymph nodes, if it is there, we will take the lymph node aspiration. Lateral flow urine lipo arabinomannan. This is TB LAM assay. This is not available as per our centers. So we will not talk much on that. Next is the cryptococcal infection. This cryptococcal infection causes meningitis in the child. This is more than 10 years. So we will do the blood test as well as lumbar puncture to prove it that yes, there is a cryptococcal infection. For malnutrition, we are going to see the weight for height and height for age, mid-arm circumference. We will check between children, all children coming to our center between 6 months to 5 years. Now, treat. When we have screened for tuberculosis, cryptococcal meningitis, infections, and malnutrition, then we will come to the treat. T for treat. Is it not so? So treating what? TB, pneumonia, bacterial infection, cryptococcal meningitis, and SAM. So all these 5 things we're going to treat. Then optimize. Optimize what? We should start the ART therapy as early as possible. Okay. As early as possible. So first we have to stabilize the child and we should start the child. And if the child is in hospital before discharge, we will give them the optimal regimes. So before that, what we do, once the patient comes to us in our centers, do we give off the drugs like we give for any other diarrhea, malaria, and send them off? No. What we do preparedness counseling, adherence counseling. Do we all do or not? All counselors. So do we do it or not? We do the preparedness counseling and adherence counseling. And then we will tell them about the therapy and we will start the therapy. Now comes the prevention. So S is screening, T is treatment, O is optimize, and P is prevent. So what all we prevent? We prevent the bacterial infection and pneumocystis carinii infection. For that, what we do? CPT therapy we will give. Is it not so? Cotrimoxazole prophylaxis we give. TB prevention we will do in children above 1 year of age. Yes. So here what we do, we will give the ILPT regime also for them. Yes. Then what we will do, cryptococcal meningitis, we will start a fluconazole preemptive therapy. Then most important is immunization. If you immunize the child is getting prevented by so many infections. Tropical infective diseases can be prevented through giving immunization. Then we will do vitamin A prophylaxis, we will give iron therapy, we will give regularly growth monitoring, we will do, and we will deworm the children. Last week only in February we had our national deworming day. So we have twice, on 10th of February and 10th of August, we have this national deworming day. So we give them deworming, and that will prevent the iron deficiency, and the appetite also will improve for the child. Then nutritional counseling regarding good diet, good protein, to prevent the malnutrition. So stop is screen, treat, optimize, and prevent. Screening for the infection of tuberculosis, cryptococcal meningitis, malnutrition. Treating TB, pneumonia, bacterial infection, cryptococcal meningitis, and SAM. Optimizing means you do the adherence counseling, preparedness counseling, and start ART as early as possible. Prevent infections by giving a CPT prophylaxis, IPT prophylaxis, cryptococcal preemptive therapy, immunization, nutritional advice, as well as deworming the child, starting vitamin A and iron therapy. Okay, till here everybody is okay? You are understanding what I'm saying? Should I go next? So how are we going to assess, screen, and triage? Screening, madam is saying, how should we screen? So let us see. So initial screening, what we do is triaging the baby. Triage means you have to screen them and prioritize them. Is it not so? Triaging is to classify or to say whether the child is sick, very sick, or child is very serious. So that way we have to triage. For that, we need the assessment. So we will assess for the general danger signs, general signs of serious illness. What are they? For every child, these general signs you have to check. What is there? Is the child able to drink or breastfeed? Okay. So పాలు తాగుతున్నాడా లేదా అది కనుక్కోవాలా. Is the child able to drink? పై పాలన తల్లి పాలన తాగుతున్నాడా లేదా? That you have to confirm. Then vomiting. Mother may say, yes, child is vomiting. But it is not just vomiting. It is vomiting everything the child is drinking. You are understanding? Every time the child is wet, child is throwing out. So vomiting everything. Then child has a convulsions. Or the child is very dull, lethargic, unconscious. Or the child has a stridor. So these are all the general danger signs. Whenever the child comes to you, you will ask whether the child is drinking, whether the child is conscious or dull or vomiting, or some sound is coming. In a calm child, itla sound ostunda enta ayasam unda adi check cheyala. Okay. Then for malnutrition, how you will see? You will see whether the child has edema on both the feet or not. Then you will record the weight. After checking the weight, you see the height or length, and then wait for height. You will see and check. If it is less than 3 standard scores, then it is a SAM. Or you will see the mid upper arm circumference. If it is less than 11.5, then it is a SAM. Here it is mentioned 115 millimeters, that is 11.5 centimeters, right? Or is there any other complication? The child has some infection or something, and child is not able to finish the ready to use therapeutic food. So that is an appetite test. We give them the food, offer the food, and if the child is able to eat, that is okay. But here the child is not able to complete the food offered to the child, then the child is into the SAM. Child is not having the proper breastfeeding. It can be because the child has an oral candidiasis. We don't know. So breastfeeding problem also is there. So initially we will assess the child, will screen them for all the general danger signs and screen for SAM. And then triage. Triage means the child is bad. Okay, child is not having vomiting, child is active, playing, child is okay. Is it not so? But if the child is dull, unconscious, child has severe malnutrition, yes, we will think that this child is serious and it may need a hospital admission. Right. So for particular diseases, as we said, we will have to see pneumonia, diarrhea, we will have severe bacterial infections, SAM. So for that, what are the criteria? How do we see? Suppose a child has pneumonia, have fast breathing. So breathing is very high. Intercostal indrawing will be there. So baga pakka legestunnadu, lopal sound ostundi, that is a fast breathing. So breathing fast undante how do we know? See, in children between 2 months to 1 year, the respiratory rate should be more than if it is more than 50, then there is a respiratory distress. Understand that if the child between 2 months to 1 year, the respiratory rate is up to 50, child is normal. Any child more than 50 unte 1 year tarvata, the child has respiratory distress. Okay na, 2 months to 12 months varaku more than 50 is child is having respiratory distress or pneumonia. Huh? But between 1 year to 5 years, if the rate is more than 40, you think it is a fast breathing. Ante child ki respiratory distress undi, ayasa padutunnadu. 1 year to 5 years lo more than 40 per minute. Okay. So when we are seeing for the dehydration, you see that the child's eyes are sunken. Okay. And skin pinch. You want to pinch the skin. How will you do? Over the abdomen with 2 fingers, you will pinch the skin and see, leave it over the abdominal wall. If it goes back very slowly, that is, it is taking time, it is taking more than 2 seconds, then you are thinking it is severe dehydration. Immediately వెళ్ళిపోయిందంటే no signs of dehydration. Okay, మెల్లగా కొంచెం పోతుందంటే some dehydration, కానీ చాలా సేపు పడుతుంది more than 2 seconds అంటే severe dehydration ఉంది. ఓకేనా? Then fever, you will record the temperature. So if temperature is more than 37.5 degrees Celsius, your patient has a fever, right? Then you will see for signs of meningitis. What are they? If the child has neck stiffness or small baby is there, 1-year-old child, then you will see the fontanelle. Fontanelle ikkada paina maada untadi kada. If that is bulging, then you have to see that the child is having meningitis. So when you are examining the fontanelle, you should make the child sit and then see for the bulging. Once there is a bulging, it indicates that the child has a raised intracranial pressure. The child may have meningitis. So what all we have learned? We have seen how to diagnose pneumonia depending on the fast breathing, dehydration depending upon the skin pinch and sunken eyes. Then we have seen fever if it was more than 37.5, meningitis depending upon the neck stiffness, and the fontanelle, which we have seen that it is bulging, it is meningitis. Till here all are okay? You're all with me on the same page? Now we will see SAM. How do you assess for SAM? Already I discussed that there can be edema on both the feet. Weight for height or length is less than 3 standard deviation. Mid-arm circumference is less than 11.5 centimeters. Child can have a difficulty to finish of the ready-to-use therapeutic food. Some other medical complication, as I said, can be gastroenteritis, or the patient has candidiasis, or there will be breastfeeding complication. Child is not able to drink. Can be because of oral candidiasis also. Now, we have this algorithm for advanced disease management, right? So what is happening here? CLHIV child who is less than 5 years of age, who is newly diagnosed with HIV infection, or who is re-entering care after treatment interruption. Okay, na? Treatment aapesadu. So first the child has come. What we will do? 4S TB screening we will do. Okay. So what all 4 things we ask? Either the child has cough, is the child having fever, if the child's weight gain is there or not, or history of contact with tuberculosis, right? So who does it? Our Srinivas does, care coordinator and nurse. Jaya, right? So they will see for all these 4 signs, they enter the signs, they will record the weight, height, and send it to the medical officer. Suppose in this 4S sign, the child has a poor weight gain, child has a cough, so that 4S sign is positive. So what they do? They will investigate for tuberculosis. Our medical officer will send the X-ray, then he will tell if the child can be induced the sputum, we will do the gastric aspirate, and we will send for the CB NAT. TB lamb is not done, that's why I'm not mentioning much over here. But if WHO clinical criteria is there for the stage 3 and stage 4, TB lamb can be sent. But usually in our centers, it is not done. But any child who comes, what we decided, we will do the general danger signs unnaya leva. So what is that general danger sign? Vomiting, convulsions, lethargic, unconscious child, or child is not able to drink or breastfeed, or the child has a stridor. So these things we have seen. After that, we will see whether the child has a fast breathing. So fast breathing, what I said was up to 1 year, between 2 months to 1 year, it is 50. 1 year to 5 years, it is 40. So normal is 50 and 40. But anything above 50 in a child more than 1 year or 40 more than 5 years, then you will think about child has fast breathing or chest in drawing or sound is coming, a grunt is coming. Then you will see for dehydration ki ఏమేం చెక్ చేసాము, స్కిన్ పింక్ చూసాము, సంకన్ ఐస్ చూసాము, ఫీవర్ కి టెంపరేచర్ రికార్డ్ చేసినాం. దెన్ మెనింజైటిస్ చెక్ చేయడానికి స్టిఫ్నెస్ ఉందా నెక్ కి, ఆర్ అదర్వైజ్ యాంటీరియర్ ఫ్రంటనల్ బాగీ ఉందా లేదా, ఇదంతా చెక్ చేస్తారు. సపోజ్ ఆల్ దిస్ కండిషన్ ఈస్ దేర్, then you are thinking, yes, this child is serious, we have to admit the child, then you have to or if that is not possible, you will give the basic treatment and then refer the child for the higher center for management, further management. Suppose it is not there, then what are you going to do? You are checking for the malnutrition also, and if that is there, not there, or the child doesn't have this danger signs and all those things, if the child has his danger signs and the clinical staging is third or fourth, here we will see the CD4 count. When the child has come, CD4 count, if we have repeated, if that is less than 200 cells per millimeter cube and viral loads are more than 1000, then this is what it is, advanced disease. No, as we said, the criteria is advanced disease. So then what we will do, we are going to admit this child and start off the CPT therapy. We will see for the opportunistic infection. Then we do the preparedness counseling as well as adherence counseling to the child and the caregiver. Then we will talk about nutrition. We will start on the ART therapy. So rapid ART initiation we will do as fast as possible, and we will give the IPT therapy, CPT therapy, immunization, nutrition, and we will do the intense follow-up of this child, right? But suppose this child doesn't have this severe general danger sign, like vomiting, convulsions, lethargy, stridor, if that is not there, fasting is not there, dehydration is not there, fever is not there, child doesn't have meningitis, then what medical officer is going to do? He will treat therapy, preparedness counseling will be done, ART initiation before discharge. If the child has some infection, he will treat. IPT above 1 year, we will start. Immunization and intense follow-up will be done. So standard package also we will do that. But here what is most important, you are seeing that rapid ART initiation, we will do it. We will not wait. So as early as possible, within 1 week, we do it actually. All are okay till here? You are understanding? Right? So further intensive care case finding of tuberculosis among PLHIV 4S screening. So screening of tuberculosis, what we have done? 4S screening chesnamu. Cough, fever, poor weight gain or weight loss and contact. Okay na? So this all we are doing in all our center. Suppose this was yes, then there is a tuberculosis. We have investigated for sputum and X-ray chest. TB is confirmed. We will start treatment of TB. Okay? Suppose there is no TB, what you will do? You will follow, you will assess this child and you will give the IPT therapy. Okay, we will start with IPT, isoniazid preventive therapy, right? But if the child has some other diagnosis, we will give appropriate therapy and we will consider IPT if it is needed. If there are no contraindications, we'll still start with the IPT. Suppose our 4A screening is not there. The child doesn't have cough, child has no fever, child has child is okay, no contact is there. Then what we will do? Assess the child for contraindication to IPT. If the child has no contraindication, we'll just give the IPT. But if you do that, and we will screen regularly. Petesi regularly we will screen this child and we will attach to the health facility, and worker will be informed to screen for the tuberculosis. Okay. So 4S screening for tuberculosis is okay for you. Positive on test treatment start చేస్తారు, నాట్ ఉన్న ఐపీటీ స్టార్ట్ చేస్తారు. ఇప్పుడు కాంట్రా ఇండికేషన్స్ ఉంటే రెగ్యులర్ హెల్త్ వర్కర్ విల్ విజిట్ ద ఫ్యామిలీ అండ్ సీ ఫర్ దెమ్. సో క్లినికల్ మేనిఫెస్టేషన్ ఏముంటాయి? టీబీ వర్సెస్ ఎక్స్ట్రా టీబీ. సో పల్మనరీ కాక్స్ లో ఏమేమి ఉంటాయి? చైల్డ్ మే హ్యావ్ ఫీవర్, చైల్డ్ హ్యాస్ కాఫ్, ఫెయిలియర్ టు థ్రైవ్, weight loss which is more than 5% of the body weight as compared to the highest weight recorded in the last 3 months. Last 3 months లో whatever weight is there, ఆ నంబర్ కి 5% లాస్ అయిందంటే weight loss. Okay. Or baby is not gaining the weight. 3 months back 10 kg ఉంది, ఇప్పుడు వచ్చిన 3 నెలల తర్వాత కూడా weight 10 ఉందంటే weight gain is not there. Or the patient has a contact. ఇప్పుడు కాంటాక్ట్ అంటే ఏంది? In any form of active TB within last 2 years, if the patient is having the contact with person who is having TB in last 2 years, వాడికి దగ్గు ఉన్న ఎనీ ఫార్మ్ ఆఫ్ యాక్టివ్ టీబీ అంటే పల్మనరీ కాక్స్, ఎక్స్ట్రా పల్మనరీ కాక్స్ ఏదైనా ఉన్నా యాక్టివ్ టీబీ ఉంటే దట్ ఈస్ కమ్స్ అండర్ కాంటాక్ట్ ఓన్లీ. ఓకే. సో హియర్ ఇంపార్టెంట్ ఇస్ టు లెర్న్ ద weight loss definition which is more than 5% to the highest of the recorded in the last 3 months. Contact of TB means person who is having tuberculosis, if baby is in contact with that within the last 2 years. Okay. Now, what are the clinical features of extra pulmonary cox? Patient can have lymph node enlargement. Patient may have headache, confusion, blurring of vision, that is suggestive of brain TB. Patient may have backache, joint pain, spine deformity, it can be bone TB. Patient may be complaining of chest pain, respiratory stress is there, tightness is there, inability to breathe, that is pleural or pericardial tuberculosis. Child may complain of pain abdomen. Child is not able to eat. Abdominal distension can be there, and respiratory distress also can be there, where we will say and suspect that it is abdominal tuberculosis, and it can be an abdominal tuberculosis or peritoneal tuberculosis. And we will always keep a record if the child is having a contact with TB case. As we said, if any person who is coming in contact within 2 years, it's a case positive case. So it is a contact is there with TB. So these are all the extra pulmonary tuberculosis. You are all understanding what I am saying? Yes, no? Any doubts, any questions? Please put it in the chat. Shweta, you can just ask any doubts are there, any questions are there. If they have asked in the
Sure,
chat,
ma'am.
you can please share with me.
Sure.
So, ఇప్పుడు ఈ clinical features తోని patient has come. Patient has fever, cough, failure to thrive, weight loss, cervical lymph nodes are there, headache is there, chest pain is there, abdominal pain, any type of thing we are thinking it can be TB. పల్మనరీ టీబీ కావచ్చు, ఎక్స్ట్రా పల్మనరీ టీబీ కావచ్చు. ఇప్పుడు ఇది ఉందా అనుకోండి, ఏం చేస్తాము? వాట్ ఆర్ ద డయాగ్నోస్టిక్ టూల్స్? హౌ షుడ్ వి కన్ఫర్మ్ ద డయాగ్నోసిస్? మనం అనుకున్నది కన్ఫర్మ్ చేయాలంటే డయాగ్నోస్టిక్స్ టూల్ ఏవి? సపోజ్ పల్మనరీ ట్యూబర్క్లోసిస్ ఉంటే, యాజ్ వి ఆల్రెడీ డిస్కస్, వి విల్ గెట్ అన్ ఎక్స్రే చెస్ట్ డన్, స్పూటమ్, గ్యాస్ట్రిక్ ఆస్పిరేట్ చేస్తాము, గ్యాస్ట్రిక్ లవాజ్, సలైన్ వేసేసి ఇండ్యూస్ స్పూటమ్ చేస్తాం. Last, we can do the bronchoalveolar lavage also, and that sample can be sent for CBNAT. Now, gastric aspirate sampling is done in children less than 3 years of age. Aim chestaru, early morning 2 samples of gastric aspirates are taken through the nasogastric tube. Right. One more test we can do is MAN2 test. It is a standard tuberculin test, which can be given on the forearm. Okay. And this PPD is injected intradermally. ఒకసారి ఇంజెక్షన్ ఇచ్చినాక after 48 to 72 hours we will check for the induration. Right. For suppose, as I said, abdominal TB అంటే ఏమవుతుంది? Abdominal distension అవుతుంది, pain అవుతుంది, patient may have diarrhea, patient may have inability to eat. అలాంటప్పుడు we will get an ultrasound done. Suppose the child has a big cervical lymph nodes. So what we will do fine needle aspiration, or we can excise the lymph node. We will send the sample for biopsy. fluid cytology to confirm. Suppose a child has headache, blurring of vision, backache, avanni unte neuroimaging CT scans should be done to confirm the CNS tuberculosis. Right? So what is the main difference for screening the cryptococcal disease? Here, see, adolescents and adults ki deeniki em teda unte routine cryptococcal antigen screening and preemptive therapy are not recommended in children less than 10 years. About 10 years unte we will start off fluconazole, but here we will not do. Okay na? But suppose the child is presenting with signs and symptoms of meningitis. What are they? Just now I told. No, there can be headache, neck stiffness will be there, anterior fontanelle is boggy. సో క్రిప్టోకాకల్ మెనింజైటిస్ ఉంటే మనం కరెక్ట్ గా అప్రోప్రియేట్ ఇన్వెస్టిగేషన్ చేస్తాం, అంటే ఇమేజింగ్ చేస్తాము, సిటీ స్కాన్ చేస్తాము, లంబర్ పంచర్ చేస్తాము, సీరం శాంపిల్స్ పంపిస్తాం, సిఎస్ఎఫ్ శాంపిల్స్ టు ప్రూవ్ cryptococcal meningitis, and then we will start likely therapy of fluconazole. Okay, now you will screen for malnutrition, right? So most common you see is SAM presentation in the child who has come to first time. We come and you see that the weight and height is less, weight for age is less. So child has all features of SAM, visible edema is there, and we said mid-arm circumference is also less than 11.5. So SAM features anni untai many times when the child first time presents to us. So we have to assess every child for seeing the malnutrition, and counselors who are all there in this group should remember to stress upon the nutrition. So as I said, the nurse and the CCR will take the anthropometric measurements, decide whether there is malnutrition or not. So weight for height, weight for age less than 300 deviation. You might be thinking again and again, madam is saying the same point. Suppose a child is coming, you have to identify malnutrition, see the weight, height, and see for any other infections is there, edema is there. You have to likely the child hospitalize the child and send to the higher center if you are not able to manage at your center. So now coming to treatment of tuberculosis in CLHIV patients. So there can be a possibility that the child is sensitive to the drugs, or sometimes you in adults have seen that the adults may have drug resistance tuberculosis. So likewise, we will see if the child is sensitive to tuberculosis, if that is resistant, how to treat. So what are all the different tuberculosis treatment guidelines? Let us see this. So what are the four main drugs we use? We use isoniazid, rifampicin, ethambutol, and pyrazinamide. Right. So doses you see 10, 15, 20, and 35. So isoniazid we usually give 10 mg per kg, rifampicin 15 mg per kg, ethambutol 20 and pyrazinamide 35. ikkada మీరు బై హార్ట్ చేసే అక్కర్లే, ఇవన్నీ చార్ట్స్ కూడా మీ దగ్గర ఉంటాయి, because it is very difficult. The medical officers might be knowing it, and it is very important to know the drug doses, because more doses if you are giving these drugs are going to be for long time. The child may have liver toxicity. Drug toxicity is very, very common. So daily dose schedule for pediatric patients up to 18 years, what we do is we have the weight band. So for patients we give the dispersible tablets, right? So suppose a child is coming between 4 kgs to 7 kgs, we will give this three combination is there, right? Intensive phase and continuation phase. You all know that intensive phase lo what we do, HRZD, we will continue all four drugs in the intensive phase. In the continuation phase, we will give HR and E, right? So we have the drugs in different package. The HRZ comes in one tablet. Okay. Sometimes we have HR as a also one different dispersible drug. So weight bands have to be recorded, and how many tablets should be given likewise you should know. So suppose the child is between 4 to 7 kgs, we have one tablet. Suppose the child is 10 kg, how many tablets you will give? Intensive phase law, 2. Suppose the child is 25, how many you will give? Write in the chat box. You're answering or sleeping? Child was 32 kgs. What you will give? 32 kgs ఏమి ఇస్తాము ఇంటెన్సివ్ ఫేజ్ లో ethambutol 2 tablets plus HRZ 2 plus 2A. 2A అంటే adult కదా. A is adult tablet you can give. In the continuation phase, likewise, we will give HR, which comes as a single package, and E separately. Okay. Just to minimize the number of drugs. We have this combination. We have this dispersible tablets. This has to be taken early in the morning, empty stomach. You remember that. And along with that, we should give them what drugs we give? What drugs we give? Anybody? What one the complication of INH is? Neuropathy. Now for that, what will give? B6, right? Pyridoxine will give, right? So further going ahead, what we do? Suppose ART therapy we should give along with the 2 HREZ plus 4 HRE, right? So how we combine that? We will see. Suppose the child is having weight less than 20 kgs and age less than 6. ఇది ఒకటి గుర్తు పెట్టుకోండి ఇక్కడ నంబర్స్. Age is less than 6 and weight less than 20. Here we will give abacavir, lamivudine twice daily as per the weight band plus lopinavir, ritonavir and super boosting with additional ritonavir. Okay na? Extra ritonavir we will give twice daily. Okay na? ఇది ఎప్పుడు వరకు ఇస్తాము? This we will give even after stopping the rifampicin containing drug. 2 weeks తర్వాత కూడా కంటిన్యూ చేస్తాం super adding of ritonavir. This you should remember. Suppose the child is more than 20 kgs and the age is also above 6 years. What you are going to give? You will give abacavir, lamivudine twice daily and you will give dolutegravir. So here you will give dolutegravir 50 mg extra. Right. Why? You are going to give after 12 hours because we give a single dose only. So you are going to give after 12 hours again one tablet of 50 mg dolutegravir because this rifampicin will reduce the effect of the dolutegravir as well as ritonavir. So that's why we will super add it. Okay, extra you have to give. You got it? Here you understand that along with your ATT when you are giving, when you are adding the ART drugs, you have to extra add the ritonavir, extra add the dolutegravir. This thing you remember. So TB infection, CLHIV on protease inhibitor. Same, rifampicin suppresses the bioavailability of azetunavir, ritonavir, lopinavir, ritonavir or darunavir. So we will do what? We will extra add it. Rifabutin is good drug, but it is not available. So we'll not discuss much on that. But here, once it is tuberculosis is diagnosed, what we do is we are going to start off the drugs. So when you are using rifampicin, we are going to super add with ritonavir. So suppose in case we have rifabutin, then it is very nice. So we need not be super boosting. Okay. So if you are not doing that, then there will be emergence of drug resistant mutants and your ART drug failure will. That's why you have to do this again and again. I'm stressing this point to super boost it only for a reason that there will be drug resistance and we will have ART failure, right? So if the child is more than 6 years, weight more than 20 kgs, we are going to boost it with dolutegravir given twice daily. So super boosting of lopinavir with ritonavir is recommended in child in proportion of 1:1. And if the age is more than 6 years, weight more than 20 kgs, we are going to give dolutegravir twice daily. See, two times I am repeating only for one reason. But certain situations we want to see here where the mother is pregnant and lactating, we will continue HREZ for her safe pregnancy and lactation. Suppose we have to start off, mother is having a drug resistance. That is what I was saying. If the mother has drug resistance, we have to start the second drug, third drug. So which drug we can give and which we cannot give? See, here we will not be able to give mother amikacin or streptomycin. Why? Because the child may have hearing defect. Okay, 8th nerve palsy might 8th nerve effect avutadi. So we will not give the mother this amikacin or streptomycin because the child may be born deaf. We will not give fluoroquinolones. Fluoroquinolones ante em istaru ikkada ciprofloxacin avanni ivvamu. Why? Because there will be defect in the cartilage in the baby. So development of bones sariga avvayu. Anduke in the fetus there is a cartilage developmental defect. So we will not give Cifran. That is also second line drug. Ethionamide is contraindicated. Why? Because the child can have a teratogenic effect. So we don't give at all. So now this another thing is bedaquiline and delamanid. These are the drugs which are the drug resistant drugs. So these drugs we will not give. Why? Because danki safety anta trials avvaledu. So we don't have more evidence to say that yes, these drugs are very safe. So shorter course of oral bedaquiline containing MDR RRTB cannot be administered during resistant TB. Mother ki resistant TB undi and she is pregnant. Because of the safety for the baby, we will not give these drugs. Among the ART, dolutegravir, efavirenz containing regimens are very, very safe. Okay, for the mothers, if you have to give dolutegravir and efavirenz can be given. But so they can exercise opt-out option for dolutegravir. You all know dolutegravir is the drug we are using, but opt-out facility is also there for them. So they can always opt out if the mother wants. But these are the drugs which will not give in pregnancy. That is injection amikacin, streptomycin, Cifran, ethionamide, and bedaquiline and delamanid. We will not give for the side effects on the babies. So now stop lo em chesamo, we did the screen, we have treated, now we have to optimize and prevent. So what we thought, what did I say? Prevention can be done by what? We will give immunization, we will tell about nutrition, we will give vaccinations, and CPT and IPT prophylaxis system. But optimize ante em chestamo? Optimize. So we will do rapid ART initiation. I said that rapid ART initiation we should do within 7 days of diagnosis. And in children who need hospitalization, we have to stabilize them. Are madam, chepparu drug fast ga start chesalan start cheyaddu. We have to treat the malnutrition, treat the meningitis. Child ki convulsions vastunayi, headache undi, child is very sick, TB undi, child is having severe respiratory distress. As we said, no. The child has a respiratory rate, fast breathing undi, daniki oxygen istamu, stabilize chesinankane we will give the ART. So as early as 7 days we should start. Okay, initiating ART is encouraged as part of the child's hospital admission. And what we can do is, this is the most important thing for all of you all. You should use the linkage facility. Okay, so that the child's HIV drugs also are given and the discharge, even if it is child is critical or you are referring to somewhere, the child is stabilized, child needs the management for malnutrition, meningitis, tuberculosis, simultaneously ART also. So linkage facility should be very good. Now CPT desensitization. So what is the CPT is given for what? We give for PCP pneumonia. All agree on that? Are we giving it or not? So this PCP pneumonia, basically it is a fungus, ubiquitous fungus. This causes what? Child will have lot of tachycardia. Ayasam osta untadi. Dyspnea will be there. This is why, because the alveoli are clogged. So what happens? Child will కొంచెం ఆయాసం ఉన్న suddenly there is a rapid progress of this disease. You understand this? So mild ఉంటే when you are seeing the saturation, pulse oximeter saturation చేస్తామా, దాంట్లో ఏమైతుంది? When it is mild, you will say that the saturation is between 70 to 79, moderate is between 60 to 69, and severe is less than 60. So saturation start to fall very rapidly. Child may become blue. So, and when you are auscultating, there will not be very great sign, but on x-rays you will see ground glass appearance will be there. Child may have high grade fever. Lab test పంపిస్తే child may have LDH raised, and we have to diagnose the child by doing the bronchoalveolar lavage, or we have to do the stain. Right, Jimsa stain is done, you will identify the cysts or trophocytes, and that is a PCP. Pneumocystis carinii or pneumocystis girovesi we call it. That pneumonia has to be diagnosed. And sensitivity, suppose we have started with this clotrimazole and the patient gets sensitized. Sensitivity unte em chestamo, slowly dose మెల్లమెల్లగా పెంచుతుంటాం. So first day we start with low dose 80, then 160, then 240, 320, 400, and lastly final strength of 800 we will give. So these are the slow sensitization we should do. Okay. So likewise, oral suspension comes in the form of sulfamethoxazole is 200 mg and trimethoprim is 40. So this slow sensitization should be done, but still the child is, a patient is having the sensitivity, patient has a rash, patient has Stevens-Johnson syndrome, atlantic unte, we will stop off clotrimazole and option drug will be dapsone. So how do you give, whom do we give, whom to give, and when to stop? All of you please be alert while listening, don't sleep, because I'm not able to see you and interact with you. Okay, so what I am telling you is, whom are we going to give? We are going to give to all HIV exposed infants. So whosoever is HIV exposed, the child is seen 6 weeks till 18 months at least will go on continuing, because the child is just exposed. HIV exposed unnadu, HIV positive kaadu. HIV positive confirmation eppudu avutundi? 18 months ki avutundi. So first encounter, patient vachindi, baby, small baby has come, mother might be positive and this child has come 6 weeks ki we will start off the child on CPT, because the child is HIV exposed. But we can stop this when at 18 months we will diagnose it. At 18 months we have seen that there is no HIV, so we will start. Or HIV is there, antiretroviral therapy we will continue, right? But all children up to 5 years who are infected, regardless of the WHO criteria, whatever may be the stage, whatever might be the CD4 count, you will start off. So you will continue with the CPT therapy. ఇప్పుడు ఈ CPT థెరపీ ఇండికేటర్స్ ఏముంది? ఇమ్యూన్ సిస్టమ్ ఈజ్ ఇంప్రూవ్డ్ అంటే ఏం చేస్తాము? we will see the CD4 count. Is it not so? We will see the CD4 count, and if the CD4 count is more than 350 cells per millimeter cube on 2 occasions, ఏ occasions? 6 months apart. ఈ రోజు చేసి రేపే చేసి ఓకే అయిపోయింది అని కాదు. So 2 occasions which are not less than 6 months. So 6 months ki CD4 counts manam elago chestam. Appudu chesinappudu, if the count is more than 350 and the patient's WHO staging is 1 to 2, then we can stop. Okay na? Clinically the child is okay, and till 5 years we will continue. Suppose the child is HIV infected more than 5 years, WHO staging is 3rd and 4th stage, and regardless of the CD4 count, you will start of the clotrimazole. But when the clinical and immunological indicators are improved, immunity is improved, and for 6 months in the child more than 5 years, the stage has come to 1 or 2, and the CD4 counts are more than 350 millimeter cube on 2 occasions, 6 months apart, then you are also going to stop. Okay na? Should we continue as secondary? Yes. So if you have treated for PCP pneumonia, after completion also you will continue. Till when? If the child is less than 5 years, you will still continue. If the child is more than 5 years, in till the child becomes stage 1 or 2, or the CD4 counts are more than 350 cells, which you will check 2 times after 6 months. Okay, kya? Got this slide? Understood this slide? So all HIV exposed children, you will continue 6 weeks till 18 months. Any child, whichever might be the WHO score or staging, sorry, or the child CD4 count, we will start off the therapy and see, check for the CD4 count. If it is more than 350 and the child's immunity has improved, the child's WHO staging has reduced, it has come to 1 and 2, then you will stop. But any child less than 5 years, you will not stop if that is HIV infected. Okay, na? Got this slide? So same thing will continue. So how you will do it? 5 mg of trimethoprim. You will calculate according to the 5 mg of trimethoprim, 5 mg per kg. So this comes in a syrup form. You can give it up to 2 months, 6 weeks to 2 months, 2.5 ml, likewise 5 ml, 7.5 ml, 10 ml, and children more than 5 years, you give 15 ml. Small tablets also come. Tablets, trimethoprim, it is 20 mg in that. So you will give 1 tablet, 2 tablets, 3, 4 tablets, and children between 2 to 5 years, you'll give 4 tablets, right? Suppose they have only adult tablet, likewise half tablet, we can give up to 10 kgs, between 10 to 15 kgs also half tablet, and children who have 2 to 5 years and weight is between 15 to 22, we will give 1 tablet, right? What we have to tell? You have to tell that this does not cure and treat HIV infection. Please understand. This is very, very important, because they will think that this drug is given, no, this syrup is given, HIV is cured. No, not at all. So we need to stress upon this. Stress upon the side effects of cotrimoxazole and when should they come back to us. And if they have this rash, liver disease, anemia, pancytopenia, and Steven Johnson, we should discontinue. Okay, na? Okay. So IPT ఎప్పుడు ఇస్తాము? So in children who are more than 1 year and 4S symptoms were negative are unlikely to have active TB. Okay. But infants aged less than 12 months but living with HIV patients who are in contact, as we said, contact ante enti, who have any type of tuberculosis within 2 years. So they are unlikely to have active TB on an appropriate clinical evaluation, right? So in these patients, you are going to continue. Whom are you not going to give IPT? Where they have hepatitis, they have neuropathy, you have hepatotoxicity, they have MDR TB, or who have PLHIV has completed the therapy of multi-drug resistant. Already drug resistant ఉన్న వాళ్ళకి ఈ బేబీకి ఐపీటీ ఇస్తే పెద్ద లాభం లేదు. ఆర్ యాక్టివ్ టీబీ డిజీజ్ కి ప్రొఫిలాక్స్ ఇయ్యము, మొత్తం థెరపీ ఇస్తాం కదా. సో ప్రొఫిలాక్సిస్ చార్ట్ ఏముంది? How much we should give? See, INH adult and adolescent tablet contains INH 300 mg and pyridoxine 50 mg, that is B6. This will give every day for 6 months. So how you will give? Weight less than 5 kg unte half tablet istamu, up to 10 1, 10 to 15 1.5 tablets, ante every 5 kg ki half tablet penchutam. Okay na? Adult tablet. Here we have 100 mg tablet of INH for children. Okay. Which is calculated 10 mg per kg. That's why for kg we'll give half tablet. Okay. Never give half to adult tablet to the babies. We have to give this pediatric doses only we have to give.
Thank you so much, ma'am. Ma'am, there's a question in the chat box. For how many days should IPT therapy be given?
So here what we have to see, how many days we have to give? Anybody? 6 months. 6 months we will continue. Okay. And suppose if the child turns out to be active tuberculosis, we will give the active regimen again, HRZD plus HRE, we will continue. Then suppose the patient gets into the contact, again we have that 4S symptoms. Okay. And they turn out to be active tuberculosis, we will continue with the tuberculosis management. Those who are not there, up to 6 months, we will give this course. For whom all we are saying who are in the contact. Okay. 4S symptoms negative. But having contact, we will still continue for 6 months. Okay.
Thank you, ma'am. Participants can now unmute their mic and ask questions. They
Any
can even,
any further questions?
nothing in the chat box, ma'am. Participants can now.
Okay, I hope if they, I hope they have understood this topic. It is a very important topic because the mortality will become very high in children who have advanced disease, and 50% of the mortality can be there in those children. So if you have to really reduce the incidence of HIV, we have to stop. The stop should have is the catchword there for today. We have to stop by screening, by treating, by optimizing, and by preventing. So all these things you should remember. Go through the slides again. Any doubts, anything, you can always ask, or the mail is there, you can contact us. Go through the topic again, or any questions right now also you can ask. Right?
Everyone has been given mic access. You can unmute and ask questions, or you can type questions in the chat box.
Hello.
Yes, sir.
Hello, ma'am. I am from hospital. Hello.
Yes, yes. Hello. Please.
IPT is given for 6 months.
Yes.
We should repeat it after 5 years or 6 years or 10 years. Is it lifetime once we have to use IPT?
Sir, can you come again? We should not repeat, sir.
IPT is given once in a lifetime.
Yes. For 6 months we'll continue. We will keep the child in follow-up, kada. So
Okay.
anytime the child has this 4S symptoms are there, or the child develops the tuberculosis, then we will have to start off the TB therapy regime. This is only a prophylaxis therapy, na sir?
Okay. Once in lifetime we have to give, we have to follow up the child.
Yes.
Okay, thank you.
Every visit, because MMD na multi-month dispersion we will do for the drugs. This child will come for our follow-up for the weight, height, nutrition. We will evaluate this child for CD4 counts, for the viral loads. So whenever they are coming to us, we are going to evaluate and seek again, do the 4S screening and do the WHO staging for these children. And if need be, if they have come into contact with tuberculosis, we will assess them according to the X-ray or gastric lavage we will do, or extrapulmonary tuberculosis is there. Suppose they are getting diagnosed as tuberculosis, we will start the TB regimen completely. Kada?
Thank you, madam. Thank you.
Yeah.
Any question?
Any more questions?
So thank you very much. I hope this has been an important class, and you all have benefited by this session. Kindly go through the slides and go through the material. If any doubts are there, you need to know how to diagnose that and stabilize the patient and refer in the advanced disease whenever you are suspecting SAM, malnutrition, dehydration, the patient has pneumonia. So you need to identify them, triage them, screen them, stabilize the patient, and give the necessary therapy and refer them to the higher center or higher facility. So thank you very much.
Thank you so much, ma'am, for facilitating this session. I'll quickly run the feedback form, ma'am. The feedback form is now visible on your screen. Participants are requested to please answer all the 4 questions. The next RDLS session will be conducted on next Wednesday, that's 1st of March from 2 p.m. to 3 p.m. And the topic is care of CLHIV post-ART initiation. For care of CLHIV post-ART initiation, you can refer to the chapter number 3.4 of the National Guidelines for HIV Care and Treatment.
That is a good point, that if you give them that topic beforehand, they also read, no? So they may,
Right,
this
ma'am.
will be a revision, and this is a very important sessions, I feel. Personally,
Right.
I feel it is very important for all of them who are
Yeah, this
working
was a
in
suggestion that came from Dr. Puri sir, DDG NACO. He suggested that we should put this in every flyer, the reference topic which they can refer before attending the session.
Yeah, and much beforehand only you are telling what is the next topic we are going to deal. So they have enough time to at least go through
the
and
topic.
read, and
Yes, ma'am.
if doubts are there, they can clarify with us.
Yes, ma'am.
Okay, thank you so much.
Thank you so much, ma'am. I'll just end the e-poll at 50% attendance and then conclude the session, ma'am. Thank you for joining.
Some are neutral. They feel that it is not important, wasn't worth it.
Requesting all the participants to please attempt the feedback poll. Thank you, everyone. We'll conclude the session now.
Thank you, madam. Thank you.